A warm good evening to one and all watching this session. I thank Oro Siksha, Dr. Prajna sir, Academic Director, Aravind Eye System, and ma'am for giving me this wonderful opportunity. Today, I'm going to deal with physiology of eye. Eye is a beautiful organ. It helps us see and experience the outside world. Coming to the fundamental, let's see how the eyes helps us see. The light passes through cornea, which is the window of the eye. Then through anterior chamber reaches pupil, which is the round opening in the iris. The iris dilate or constrict, determining the amount of light entering the lens. Then it travels through clear fluid known as vitreous and reaches retina. The retina converts the light impulses into electrical impulses and transmits through optic nerve, which is a second cranial nerve, through the back of brain where visual cortex is located. This is how we are able to see things. In this lecture, I am going to deal with tear film, cornea, pupil, aqueous humor, and lens. And my colleague will deal with physiology of retina and stuff. Tear film. What is tear? Tear is a liquid product of the process known as lacrimation. It cleans and lubricates the eye. It is also known as precorneal film because it is present in the outer surface of cornea. The thickness is 7 to 8 micrometer, volume is 7 microliter, and pH is 7.3 to 7.7, which is compatible to plasma pH. The refractive index is 1.357. Coming to layers of tear film, as you have seen in previous lecture, it has 3 layers: lipid, aqueous, and mucin. Lipid layer is the superficial most layer. It reduces evaporation of the tear film and helps in lubrication of eyelid movements during blinking. Aqueous layer. It provides atmospheric oxygen to the cornea and cleans the deprives. It also has antibacterial activity. Mucin layer is a close present to the ocular surface and lubricates them. Have you thought about how often we blink? On an average, we blink about 15 to 20 blinks per minute, up to 1200 blinks per hour. Let's see what happens during blinking. The tear film lipid layer, which is the superficial most layer, get compressed during the downstroke and redistributes during the upstroke of the upper eyelid. Since the main function of lipid layer is to prevent the evaporation of the tear film, this process helps in maintaining the tear film stability and by preventing the formation of dry spots. So if you have a longer screen time, like using phone or laptop for a longer duration, we forget to blink much, resulting in dry eye. Tear film breakup time. It is an interval between the complete blink and the appearance of a first randomly distributed bright spot on the cornea. It is illustrated by staining with fluorescent stain and examining in slit lamp under over blue light. Normally, it happens after 15 to 35 seconds. If it happens less than 10 seconds, it depicts tear film instability. Next is Schimmer's test 1. It is a quantitative test. It measures the total tear film quantity. It is measured with the help of Whatman 41 filter paper. It is placed in between the inner 2/3 and the outer 1/3 of lower lid. Usually, the patient is asked to look up and not blink. Usually, after 5 minutes, the tear may wet more than 15 millimeter of the reading. If it is less than 5 millimeter, it depicts severe dry eye. Let's see how the tear film flow. Majority of the product is produced by the lacrimal gland. It passes and spreads throughout the eye and get collected near the punctum. Then through canaliculus, it passes through lacrimal sac. Then it get eliminated through nasolacrimal duct. Lacrimal syringing test. Since it is an invasive test, we have to do under the topical anesthesia cover. A normal saline is pushed into the lower punctum with the help of a syringe and the lacrimal cannula. If there is an obstruction in the same canaliculus, the fluid gets regurgitated from the same punctum. If it is beyond it, that is in sac or in nasolacrimal duct, it gets regurgitated through the opposite punctum, hence ruling out the mechanical obstruction. Cornea. Cornea is a transparent avascular structure covering the anterior 1/6 of the eye. The major function is optical and barrier function. It forms a principal refractive surface accounting up to 70% of the total refractive power. It protects the intraocular structure from the outer environment. It also helps in absorption of topical drugs. Since it is an avascular structure, it gets nourishment from the atmospheric oxygen through tear film and through aqueous humor. Let's see how the cornea maintains its transparency. It maintains through anatomical and physiological factors, namely corneal epithelium and tear film. The uniformness of the refractive index throughout the epithelium maintains the transparency. The regular arrangement of corneal lamellae. The corneal collagen fibrils of uniform size are arranged in such a way that it forms an exocanal lattice appearance. This appearance prevents the light scattering. In case of swollen cornea, this structure is disrupted, resulting in loss of transparency. Avascularity of cornea. If there is a corneal vascularization, it results in loss of transparency. Physiological factors include barrier functions of limiting layers, that is epithelium and endothelium. The thick cell junction between the epithelial cells prevent the fluid leak into the cornea. And whereas endothelium hydrates the cornea through leaky barrier and fluid pump. The excess fluid in the stroma get pumped out through endothelial pumps, namely sodium-potassium ATP pump. This is a normal cornea where we can see what is inside because of its transparency. But this is a decompensated cornea where it lost its transparency due to the vascularization and corneal hydration. Let's see how we are able to see cornea in slit lamp. The illumination should be placed at 45 degrees to the viewing point. The outermost line is an epithelium, the innermost is an endothelium, and the central part majorly comprised of stroma. If the fluid gets accumulated in the epithelium, it looks like a bubble-like structure where it is also known as microbullae or macrobullae. If the fluid gets accumulated in the stroma, the central part is bulged out, appearing like a spindle. Here comes the question. Why is cornea clear? A. Uniform arrangement of myocytes. B. Uniform arrangement of fibrinoblasts. And C. Uniform arrangement of collagen. Here, poll starts now.
Please enter your response and don't forget to hit submit after you choose your answer. I'll give you a few more seconds to respond. I hope all of you are able to see the quiz. Mr. Kalyan, I see your hand up. If you're not able to enter, you can maybe respond in the chat box. Okay. So I'm going to just show you the results that we received.
It's true. Majority of answered correct. It's uniform arrangement of collagen. Here goes the second question. What is the function of corneal endothelium? Push the cells upwards, pump excess fluid out of stroma, and provide thickness for cornea. Let's start the poll. Over to you, ma'am.
Just a minute. I'm going to close the poll now.
Yes. It pumps the excess fluid out of stroma. It's correct. Pupil. Pupil is a round opening in the center of iris. The normal size is 3 to 4 millimeter. The sphincter pupillae muscle is a circular muscle. It constricts the pupil, whereas dilator pupillae is a radial muscle. It dilates the pupil. Coming to the clinical correlation. The pilocarpine drug directly acts on the sphincter pupillae muscle, constrict the pupil, whereas phenylephrine directly acts on this dilator muscle, cause dilatation. The commonly used drug known as atropine, tropicamide, cyclopentolate acts on this sphincter pupillae muscle, cause restriction of this meiosis, ultimately leading to dilatation of the pupil. Light reflex. When the light is shown onto the pupil, the stimulus reaches the retina, where the stimulus is carried out through afferent pathway known as optic nerve. It reaches a part of brain known as pretectal nucleus. The fibers then reach out to Edinger-Westphal nucleates of both sides. The efferent fibers carried out through ocular motor nerve, which is a third cranial nerve, and rely on ciliary ganglion, and ultimately reaching to sphincter pupil muscle, where the constriction of pupil occurs on both sides. The constriction of pupil on which the light is shown is known as direct reflex. That of the other is known as indirect reflex or consensual reflex. Requisite for examination of light reflex. Keep the room dull as possible. Ask the patient to look at a distant target. Swing bright light source in a quick motion on the eye. What you going to observe? We have to record whether the reaction is brisk or sluggish, well sustained or ill sustained. This video shows that the constriction of pupil on which the light is shown is known as direct reflex, and that of the other is known as indirect reflex. This shows that the light reflex pathway is intact and it is responding to the light. RAPD. Relative afferent pupillary defect. If there is a damage to the optic nerve or a severe retinal disease, this occurs. That is, if there is a damage to the pupillary nerve or a severe retinal disease, the stimulus does not reach the brain. So, there is no constriction of pupil resulting in paradoxical response. Here we can see that right is normal, whereas left is abnormal. Clinical graining of RAPD. Grade 1 is a weak initial constriction and greater redilatation. Grade 2 is an initial stall and greater redilatation. Grade 3 is an immediate pupil dilatation. Grade 4 is an immediate pupil dilatation following prolonged illumination of good eye for 6 seconds. Grade 5 is the immediate pupil dilatation with no secondary constriction. Moving on to aqueous humor. Aqueous humor is an optically clear fluid that fills the anterior and posterior chamber of the anterior segment. The flow rate is 2.5 to 3 microliter per minute. The volume is approximately 250 microliter. The refractive index is 1.3 and pH is 7.2. Let's see how the aqueous flow in the eye. The aqueous is produced by a unique structure in the eye known as ciliary body. It is present beneath iris. The flow passes through the pupil and exits through a drainage system known as trabecular meshwork. There is a normal balance between the fluid that produced and the fluid that exits through the eye, thus maintaining a normal healthy pressure within the eye. Functions of aqueous humor. It maintains a proper intraocular pressure. Metabolic and nutritional role. It provides nutrition to the and lens, and also removes the waste from them. It provides an optical transparency. It cleans the blood, remnants of lens, and any products of inflammation present in the anterior chamber, thus acting as a lymph in the eye. Aqueous humor formation. It is formed from the ciliary blood vessels through ultrafiltration, secretion, and diffusion. Moving on to the clinical relevance. Let's see the anti-glaucoma drugs and its acting site. It is majorly divided into the drugs acting on the production site of the aqueous and the outflow site of the aqueous. Alpha agonist, namely brimonidine, directly reduces the ciliary blood flow by constricting them. Beta blockers like timolol and carbonic anhydrase inhibitor like diamox and dorzolamide act at the cellular level at the ciliary process and reduces the aqueous flow. The aqueous flows out through two pathways, namely trabecular outflow and uveoscleral outflow. Prostaglandin analogs increases both trabecular outflow and uveoscleral outflow, whereas pilocarpine increases the trabecular outflow and decreases the uveoscleral outflow. Intraocular pressure. The intraocular pressure refers to the pressure exerted by the intraocular fluids onto the coat of the eye. The normal IOP is 10.5 to 20.5. It is maintained by a dynamic equilibrium between the formation and the outflow of the trabecular flow. Increase in the IOP damages the eye. Let's start. And another question. Which is the drug that facilitates the aqueous humor outflow? A. Timular, B. Pilocarpine, C. Dorzolamide, and D. Brimonidine. The poll starts now. Let's see the answers. Yes, majority of them answered correctly. It's pilocarpine, where the remaining breaths acts at the production site. Moving on to lens. Lens is a clear biconvex crystalline structure at the front of eye behind the pupil. The diameter is 9 to 10 millimeter, thickness is 3.5 to 5 millimeter. And surfaces, it has two surfaces, anterior and the posterior surface. The anterior surface is less convex than the posterior surface. Functions of lens. Lens helps us see with the help of focusing the light rays onto the retina with help of its transparency, refractive power of 15 diopter, while the rest is contributed by the cornea and its capacity to accommodate. It also prevents the ultraviolet radiation coming from outside from reaching the retina. Lens is a relatively dehydrated organ since it maintains its transparency with the help of sodium-potassium pump, as you have seen in the cornea. Since it is an avascular structure, it gets nourishment from the aqueous humor and the vitreous humor. Glucose is the main source of energy. What happens to lens on aging? With aging and the environmental insults like ultraviolet radiation, other oxidative stress, there is a loss of transparency in the lens, resulting in light scattering, coloration, and stiffness of the lens. Coming to the types of cataract. As you all seen in the previous lecture that there is an outer capsule and cortex and the inner nucleus. If the cataract occurs in the nucleus, it is known as nuclear cataract. If it occurs in the cortex, it is known as cortical cataract. It is characterized by a wedge-shaped opacity coming from the side to the center. So the visual disturbance occur in the later stage in this cataract. Whereas the posterior subcapsular cataract, where the cataract occurs just before the posterior capsule, it starts in the center and spreads peripherally. So the visual disturbance occur at the earliest stage in this cataract. Iris shadow. When the light is thrown onto the pupillary margin, it forms a crescentic shadow. It shows that there is a clear cortex in between the opacity and the pupillary margin. It is seen in immature cataract, whereas in mature cataract, where there is the lens is fully opacified and there is no clear cortex in between the opacity and the pupillary margin, there is no iris shadow. This helps in distinguishing between the immature and the mature cataract. Nuclear cataract. Grading based on slit lamp examination. Grade 1 is white or greenish yellow. Grade 2 is yellow. Grade 3 is amber. Grade 4 is brown. And grade 5 is black. Accommodation. It helps us see, focus the near object. Eye as a unique mechanism that the diverging light from the near object get converged onto the retina with the help of a mechanism known as accommodation. Here, the zonules are held tight by the lens are held tight by the zonules, but with the help of constriction of ciliary muscles during the accommodation, the zonules are loosened up. So there is a bulging out of lens. There is an increase in the rate curvature of the lens that thus it increasing the refractive power of the lens. So it helps in focusing the light onto the retina. The near reflex triad include increased accommodation, increased convergence, and constriction of pupil. The light from the near object falls behind the retina, but with accommodation falls onto the retina. On aging, because of weakness of accommodation, that is, there is a stiffness of lens capsule and weakness of ciliary muscles, there is a defective near vision known as presbyopia. Here goes the fourth question. Which structure controls the shape of lens? A. Extraocular muscles. B. Ciliary process. C. Ciliary muscles. Let's start the poll. Exactly. It is due to ciliary muscles. Thank you.